Okay, let's unpack this. Imagine you get an email. It's from, say, an insurance company, maybe an employer, and they need medical information on one of your patients.
Right.
And you get this sort of dual feeling, don't you? You want to help the patient get their claim, of course you do, but at the same time, you have this absolute duty to protect their privacy.
That tension.
Exactly that tension, the doctor's dual obligation. And that's what we're really diving into today.
And that's the absolute key dilemma, isn't it? It's where so many doctors, especially junior ones, feel the pressure. So our mission here is to sort of synthesize the GMC guidelines on this.
To give a clear map.
A clear, actionable map. Because the core truth, if you take one thing away, is this. The safest doctor always prioritizes informed consent and relevance above everything else.
Right. And that links directly to professionalism, to maintaining trust. So before we jump into the specific actions, let's just ground ourselves in the big picture. What are the bedrock principles here?
Well, you always have to start with the foundations, don't you? The 4 pillars of medical ethics: autonomy, beneficence, non-maleficence, and justice. They're the context for everything.
And confidentiality is sort of woven through those.
Exactly. It's often called the 5th pillar for a reason. It's a direct application of, do no harm, non-maleficence, and respecting the patient's choices, autonomy.
And these big ideas, they're then formalized in good medical practice.
Precisely. And what's fascinating is that all of this specific guidance on disclosure, it flows directly from just one of the 4 main domains in that guide.
Which is?
To maintain trust. I mean, it's that simple. If a patient doesn't trust you to protect their information, they won't tell you things. And then you just can't provide good care.
Which brings us right back to that central problem.
Yeah.
The dual obligation. So let's define that a bit more. When does this actually happen?
It happens when you, as a doctor, find yourself owing a duty to 2 different parties at the same time.
So there's the patient.
Always the patient first. That's your primary duty of care. It's unwavering. But you might also have, say, a professional duty to a third party.
An employer you do occupational health for, maybe?
Perfect example. Or a court, if you're an expert witness. And the risk is that what the employer needs, or what the court needs, suddenly comes into conflict with what your patient wants, with their privacy.
And I imagine these situations can just pop up unexpectedly.
They do, so awareness is absolutely key.
Okay, so if that tension is a given, how does the GMC help us manage it? What are the sort of, the hard and fast rules for handling patient data?
I think you can boil the guidance down to a few really clear boundaries. And the first one, maybe the most important, is the idea of minimum necessary.
Okay, what does that mean in practice?
It means you must always use the absolute minimum amount of personal information you need to fulfill the request. And if you can possibly use anonymized information to do the job, you have to.
That seems straightforward, but I can see a trap there. How do you know what the minimum is? Isn't it just safer to send a bit more and let the lawyer or the insurer figure it out?
And that is the classic trap. Sending more is not safer. It's a direct violation of the patient's privacy and the GMC's principles.
So your job is to be the gatekeeper.
You're the gatekeeper. You have to use your clinical judgment to decide what is actually relevant to that specific request. If a claim is about a knee injury, you don't include details about their mental health history unless it is directly, demonstrably relevant.
So you're an editor, not just a data courier.
That's a great way to put it. You are an active editor. And the other massive boundary is, of course, consent.
Which has to be explicit.
Explicit, not implied. For anything outside of their direct clinical care or maybe a local audit, you must have the patient's specific, informed, and ideally written permission.
Okay, let's make this really practical. The most high-yield scenario. You have to write a medical report for an insurance company. What is the safest step-by-step way to do this?
Right. There's a really clear 4-step professional framework here that keeps you safe and respects the patient.
Let's hear it. Step 1.
Action 1. Informed consent and scrutiny. So before you even touch the patient's records, you have to be certain they've given informed consent for both the examination itself and for the report being disclosed.
You have to explain who gets it and why.
Absolutely. And here's a crucial point. If you find something you think is relevant, but the patient says, I don't want that in there, you have to stop and address that conflict straight away.
And how do you handle that? That sounds incredibly awkward.
It can be, but your duty is to be accurate. If the information is factual and directly relevant to the report's purpose, say a previous injury they're now claiming for again, you have to include it to be unbiased.
So what if they refuse consent for that specific bit of information?
Then generally you can't complete the report ethically. You would have to inform the insurance company that you can't provide the report because you don't have the necessary consent, but you don't say what the information was.
Wow, that is a tightrope. Okay, what's action two, the content itself?
Action 2, accuracy, relevance, and minimum disclosure. So the report has to be factual, accurate, and unbiased. Stick to the facts, don't speculate, and this is where you avoid that big trap we talked about.
Right.
You never, ever default to just sending the patient's entire health record. That's a massive breach of the minimum necessary rule unless you have something like a court order.
And action three. I've heard this is probably the most important step for avoiding complaints.
It really is. It's the cornerstone of patient autonomy in this whole process. Action 3, patient review prior to release. You must, and this is a must, offer the patient the chance to see a copy of the report before it goes anywhere.
But let's be real for a second. What about the time pressure? The insurance company is on the phone, they need it in 24 hours, or the claim is off.
That pressure is a test of your professionalism. Your duty is to the patient's autonomy, not the insurer's deadline.
So you just have to push back.
You contact them and explain that the delay is because of the mandatory patient review process required by GMC guidelines. You do not skip that step. The professional risk is far too high.
Okay, that's a really clear line. And action four, what if the patient reads it and disagrees?
Action 4, amendment and documentation. If they spot a factual error, you have to support their right to ask for it to be corrected. Now, if they disagree with your clinical opinion, that's different.
You don't have to change your opinion.
No, but you must record their disagreement and attach it to your report when you send it. And finally, you document everything. Every decision, what you disclosed, and why.
So that's the framework when you need consent. But when can you just bypass it? When does the law or, public safety take over?
There are 2 main exceptions. First, if disclosure is required by law. This is for things like court orders or mandatory reporting of certain diseases. You have to comply.
But you still only give the minimum necessary.
Still the minimum, always. The second exception is what's called being justified in the public interest.
And that sounds like a very high bar.
It is an extremely high bar. This is specifically to prevent death or serious harm. For example, you find out a patient with a new dangerous medical condition is refusing to stop driving. You might need to inform the DVLA to prevent a serious accident.
Okay, so with that whole framework in mind, what are the most common traps people fall into?
The biggest one, by far, is skipping that patient review step. Sending the report without letting them see it. Even if it's perfectly accurate, you fail the autonomy test.
And the second one?
Disclosing too much. Going beyond the scope of the request. Just because you have the information doesn't mean you should share it.
What about escalating too quickly? Getting into a fight with the insurance company about their deadline?
Yes, another misstep. Your primary obligation is to the patient. So you sort out the review with the patient first, and then you manage the timeline with the insurer. It's about priorities.
So bringing this all together, it's clear that this is all about managing risk, isn't it? Not just legal risk, but the risk of destroying that fundamental patient trust.
Absolutely. Attention is real, but the GMC guidance is there to be your shield.
Right. So let's leave everyone listening with 3 key takeaways, the absolute non-negotiables.
Okay. Number 1, consent is king, and it must be specific. You need explicit consent for anything outside of direct care.
Number 2.
Be relevant, be minimum. Really challenge yourself. Is this information essential for this specific request? Never, ever send the full record by default.
And the 3rd?
Patient review is non-negotiable. Always give the patient the chance to see a report before it leaves your hands. It's their data.
The GMC guidance really does give you the tools to navigate that space between patient autonomy and your other obligations. And it's worth remembering, I think, that confidentiality isn't just a rule, it's a commitment.
It is a commitment to treating every piece of information with the dignity it deserves.
Use these frameworks and you keep your patients safe and your practice sound.